Hello, everyone. Welcome to this very important webinar for parents of young adults who suffer from borderline personality disorder and or bipolar disorder. Thank you for taking the time out of your Saturday today to be with us. We're excited to have you here, and we'll get started by introducing ourselves, and then we'll get right into the presentation agenda. So, Dr. Bob, would you like to begin?
Yes, Debbie, thank you.
Good morning.
It is a pleasure. And hello, everyone, and welcome. I'm Dr. Bob Fisher. I'm a psychiatrist and the executive director and co-founder with my wife, Ann, of the Optimum Performance Institute and ROAN programs, which you'll be learning a little bit about today. I also serve as an assistant clinical professor of psychiatry at UCLA School of Medicine in the Department of Psychoneuroimmunology, and I'm with the Mindful Awareness Research Center. But perhaps most importantly, I have a strong desire to reach and serve young people who are suffering from a variety of mental issues, to help them discover their passions, to transform, and to be equipped to build a life that they truly feel is worth living. I'm really so honored to be among so many of you parents today and look forward to sharing information with you on bipolar disorder and borderline personality disorder, to answer your questions, and to have OPI and ROAM programs become resources to your families. I'm also very, very pleased to have Debbie here for this webinar, and now she'll share a bit about her story. Debbie.
Thank you, Dr. Bob. I'm so excited to be here as well. I know many of you. I'm recognizing a lot of these names as parents that I've connected with. So hello, and hello to people I haven't met yet or connected with online. I'm excited to be here. I think highly of you, so highly of you, Dr. Bob, and also of the Optimum Performance Institute and the ROAN program. And I'm always looking for opportunities to reach the mental health community and loved ones in meaningful and helpful ways. So this collaboration definitely falls under that category. So thank you very much for this opportunity. Some of you out there already know me from the blog Healing from BPD, which I started several years ago. And at that time, my life was a mess, to put it lightly. If you follow my blog, you know that. You saw what was going on at the beginning and you watched the transformation, right? So I was very emotionally unstable. I was unable to pick and stick with a major in school. I had one failed relationship and job after another, and I just couldn't seem to manage my emotions. And really that was the problem, at the base of everything that was going on for me, with things not, following through on projects and being able to succeed in areas that I was trying to succeed in my life, in relationships, school, work, and so on. So I felt like I couldn't manage my emotions because they felt overwhelming and too intense and difficult for me to bear. The other problem was that I was very erratic in seeking services, and there were a lot of reasons for that in terms of just an unstable living situation and so on. So I would bounce from one clinic, hospital, therapist, psychiatrist to another. So an accurate analysis of my condition and an effective treatment plan that could really help me weren't established for years. So I was originally diagnosed as bipolar rapid cycling and put on meds to manage that, such as Depakote and anticonvulsant. Dr. Bob will get into medications and how they work and don't work when it comes to BPD and bipolar during this presentation, so I won't get into that too much right now. He'll also talk about why these diagnoses are often confused and how someone like me or like your son or daughter might have been going through or are going through the same situation or similar situation right now. So I'm happy to be here, and I'll also be available during the Q&A session at the end. Thank you, everyone. Let's get started. Okay, I'm going to help out here with the agenda and so on. So first of all, I'll go ahead and give you guys some tips for the Q&A session. For those of you who know me through teaching online DBT classes, this is a platform I'm familiar with, so I'm happy to let us all have a moment of, orientation to this platform so we know how to use it. And then Dr. Bob will get into some of the similarities and distinct differences between bipolar disorder and BPD. Borderline personality disorder throughout the presentation will also be referred to as BPD and bipolar as bipolar. He'll also talk about the biological and environmental contributors to both of the disorders, the very different roles that medications play, and in addition to medication, some of the most effective therapies and treatments for bipolar and BPD. I know this to be a fact for myself, and we'll talk about this more in depth, but meds alone, no matter what your condition, if it's bipolar or BPD, are not sufficient for building a life worth living. And we'll talk about what else can we integrate and bring into the young adult's life so that that life worth living can be built. We can't just rely on medication to do it. It doesn't work. So we'll also talk about why treating the whole person, not just the diagnosis, matters in recovery outcomes. And what does that mean to treat the whole person, not just the diagnosis? So Dr. Bob will talk about that. And then at the end, we'll open up for Q&A with Dr. Bob and myself. All right, so let's get started then on the very important topic of the similarities and distinctions between borderline personality disorder and bipolar disorder. And I'm going to throw it back to Dr. Bob.
Thank you, Debbie. Hello again, everyone. All right, so let's get started with the distinctions between a bipolar disorder and a borderline personality disorder. As Debbie described was her case initially, it may at times be very difficult to distinguish, to understand, and see the differences. Because basically we're observing the most external picture or images projected from a very complex person. That person is made up of both their internal worlds, which most of the time is not expressed but is exceedingly important, and their external behaviors, which are manifested for all to see and experience. So essentially, these young adults have a lot going on for them inside that we cannot see, and a lot going on for them on the outside, which we can. You might notice that your son or daughter is very emotionally sensitive. In both cases of a young adult with bipolar or BPD, both may be exquisitely sensitive. But the distinction is often made that they appear to be overreacting to stimuli. Young adults who appear to be distractible, irritable, difficult to be around. What's missed is many times it's equally difficult for that individual to be in their own skin, experiencing repetitive moments of fear and anxiety, needing to find a sense of safety, even at the expense of alienating others, which is generally not their intention. They become defensive. Is this sounding familiar? When it comes to the details of this experience, a young adult with bipolar disorder may experience a destabilization that results from a change in the balance of their internal chemistry. They may be experiencing a complex developmental, neurologic, and psychologically overwhelming experience. So what does this all mean, and why does it matter? The conceptual model of BPD that Marshall Linehan has proposed describes an exquisite sensitivity that a young person has to a complex environment that can most easily result in shifts in moods and cognitions and thoughts. And as a result of that experience, the young person is often left feeling invalidated by the world around them. Repeated invalidation can lead to not connecting with reality, and a lack of appreciation that this awful feeling of fear and disorganization that they have, it won't last forever. It just feels like it will. When the experience of feeling invalidated occurs, one becomes even more sensitized to feeling invalidated. This is the essence of a self-reinforcing, invalidating cycle. Unconsciously, we become attached to these habituated feelings of being invalidated. Sometimes we begin to beget what we put out, including fear and trepidation. A young adult who may be absolutely afraid of rejection, yet engage in behaviors that push other people away. They may do this in response to the painful emotions they have come up for them because of the experience of feeling invalidated. The young adult may honestly feel incapable and overwhelmed with pain and disorganization due to their level of emotional sensitivity. At some level, really, many of us feel invalidated, so it's really a matter of degree. There is a sensitivity scale. One may interpret an experience as invalidating when another doesn't. The person who's being accused of being the invalidator must understand that the accuser may not be manipulating or saying that they are feeling invalidated for some type of secondary gain. They may be biologically predisposed to this level of sensitivity. And even when your intention as a parent is anything but to invalidate them, it may be perceived that way. We must understand that this is a very real experience for those young adults, the experience of feeling invalidated. That's why sometimes with someone who has BPD, it's helpful to say, look, I don't understand how you're upset over all of this. Even if you personally don't agree that the situation warrants this level of emotional response, it's important to create an atmosphere of empathy and understanding. It benefits both parties. This can make all the difference.
Thank you, Dr. Bob. I just want to comment briefly on the connection you brought up between the intense emotional reaction one with BPD may have to a situation and the experience of feeling invalidated that can ensue and just cause more problems.
Yes, Debbie, please do. Please.
Thank you. Thank you so much. So as someone in recovery from BPD, I can tell you that I experienced repeated suffering after unnecessary suffering because honestly, and how could they have, but the people around me didn't know that one magic rephrasing technique that Dr. Bob just shared. So, for example, if I became emotionally distraught, actually I would call it extremely emotionally distraught as I would experience back in the day, let's say because my significant other would go away, even for a few hours, because that was my story back then, right? And of course, the emotion seemed appropriate and in proportion to my suffering at that time. And, you know, a well-meaning loved one would say something like, oh, come on, Debbie, really? He'll be back in a few hours. You're such a drama queen. Cut it out already. Like, I would hear that kind of stuff all the time. And the problem with that is that I'd be pushed even further into emotional distress because there I was already feeling vulnerable and anxious about him leaving. And now, on top of that, I was being told that there was something wrong with me, you know, that I shouldn't feel this way, and yet I did. So it definitely caused confusion, anxiety, further acting out on my end. So when Dr. Bob talks about maybe rephrasing it, something along the lines of, I can see how upset this has you. I'm sorry to see you suffering, you know, or something along those lines, I know that for myself, that response would have definitely soothed me and helped me to calm down.
Exactly, Debbie. Thank you for that. Firsthand experience is invaluable when we're trying to understand the complexity of all of this. Now, moving on from the issue of sensitivity, why is it at times so difficult to distinguish BPD from bipolar disorder? The answer is this. Both individuals may at times experience hyperactive, impulsive, manic-type behaviors, as well as depressive symptoms. However, even so, there are subtle characteristics that we can use to help differentiate between bipolar and BPD. Here's an example. Someone may be speaking very quickly. The speech may be pressured. Many people exhibit this depending on the intensity of anxiety that they're experiencing. However, if someone's speech becomes truly disorganized, or they begin to speak at such a rapid rate that they become unintelligible, or their thoughts no longer appear to be linked or sequential, that type of thinking process is more common in bipolar and really very unusual for many with a borderline disorder. That all being said, an individual with BPD may have an experience like this one, like the one I just described, But generally, these experiences are more time limited, and the stimulus for such experiences they actually tend to be more highly correlated with the perception of an event, sometimes referred to as a trigger. Sometimes a young person with BPD can become so disorganized that they employ what are called manic defenses. That brings us to the topic of mania, which is discussed more in the realm of a bipolar disorder. I'd like to chat about that. The state of mania in bipolar may evolve to an actual psychotic experience. Psychotic is a word often misused and misunderstood in our society. Medically, it's used to describe the states when one's ability to perceive the world accurately and make reasonable and clear judgments is severely impaired. In the most extreme form, the person is totally out of contact with reality. In terms of bipolar versus BPD, this is something more commonly seen in those individuals with a bipolar disorder. Basically, mentally speeding up and manic thinking is an automatic defense we all can use sometimes, no matter what the diagnosis. It is a human experience. Mania can, however, spin out of control. Thinking can speed up, and it's hard to conceptualize this, but thinking can speed up so much that an individual begins to ramble. At such speeds, he or she usually becomes irritable, since they're unaware of their rate of speech, and therefore they don't understand why they're not being understood by others. They can also get to the point where their decision-making is impaired because they're going so quickly that the images within their minds become blurred and distorted, and they're only relating to an internal dialogue and perceptions. They're no longer relating to this external world. This can really be a scary experience for you as a parent to witness. That process of your child relating to their own internal experiences and perceptions. You become aware that they're not making sense. In other words, they are not relating to reality. During this time, the young adult is experiencing so much inner noise that he or she may not be able to perceive the world accurately. It is being drowned out. He or she may cling tenaciously to their internal world, to which other people are saying, this is not happening. This is not you. Why are you acting this way? Why are you so afraid? A person in a bipolar, manic, psychotic state is not in touch with reality. It's not the same that someone with BPD can't be out of touch. So it's not to say that the individual with BPD cannot be out of touch with reality, but the quality, the experience, and the length of time of this episode seems to be quite different for those with BPD. A person with bipolar may experience a sense of omnipotence, may find themselves standing on a bridge or a roof, truly believing they can fly. This is very dangerous. And this is very different than in BPD, borderline disorder, when someone is very frustrated and not thinking clearly. But in the next few breaths or moments, they can become aware of other choices and therefore reality. A person with a bipolar cannot tap into that coherent thinking as rapidly. That's why it's so much more dangerous, and why for those with bipolar individuals, taking medications as prescribed is so important. We've covered the similarities and differences, and when it comes to emotional sensitivity and emotional dysregulation and the distinction of mania with bipolar, now let's look at the all or none, and the black or white thinking. You may have experienced this. You may have actually experienced this as your child being your best friend in one moment and adoring you, and then you say or do one little thing, but in their eyes it's a big thing. And now they are now blaming you for everything going wrong in their life, telling you they hate you, not answering the phone or returning your messages. This behavior can be very confusing and hurtful to parents and loved ones. And this is part of an automatic defense and survival mechanisms that these young adults have developed. Most of the time, they really do not mean it. They do not mean to hurt. But in the heat of the moment, we're all unskillful. But it is something that can be worked on and changed with the right treatment. So to wrap up this particular topic, there is a lot of overlap and many distinctions between bipolar and BPD. But perhaps the most profound difference is the state of depression and the state of mania experienced by those with bipolar. This is quite different. The intensity is generally quite different than those with a borderline disorder. There's also a bipolar disorder called rapid cycling, meaning intense or subtle ups and downs in a matter of hours, that these shifts in mood can occur rapidly. And this is another reason why there can be confusion distinguishing between a rapid cycling bipolar and a borderline disorder where somebody's moods may also shift rapidly. However, to further confuse things, in our present-day diagnostic system, an individual may have both disorders presenting at the same time. So it's a matter of having an available, informed, and skillful treatment team providing appropriate treatments for the whole person. We must consider the whole person. Because of the potential for misdiagnosis and therefore a delay in the young adult getting effective treatment, an immersive diagnostic and treatment experience is often an effective and efficient way to establish proper diagnoses and initiate treatment. We'll get into this shortly in the presentation.
Thank you for that, Dr. Bob. I know later in the presentation you'll be addressing how a treatment team can decipher whether someone is experiencing bipolar or BPD, and really you overviewed that just now, and how important this distinction is in order for them to get the right treatment and enter into recovery. But in the meantime, would you please talk a little bit about the unique biological and environmental contributors to the disorder so we can better understand how they generally develop in a person?
Absolutely, Debbie. I mean, this is an actual question that parents often have. How did my child, in quotation, get BPD or develop bipolar disorder? Of course, there is no clear-cut answer. And the variables that line up for someone to develop bipolar or BPD will vary from one person to the next. In general, in an individual with bipolar disorder, there seems to be a very strong genetic biologic component. There is an internal biologic sensitivity to stimuli. For those who have experienced bipolar depression and mania, meds are essential. They're an essential part of the treatment, and we'll discuss that. In bipolar disorder, the individual's worldview is often distorted due to internal chemical imbalance. In BPD or borderline disorder, the young adult is often very sensitive to their perception of external things or issues occurring in their external environment. With BPD, with borderline disorder and sensitivity, the question is, where did it start? Well, generally, if we assume and say that one's genetics plays a role in everything, including our predispositions and sensitivities to different environmental stimuli, be it intimacy, fear, love, anger. We're all wired to respond within given parameters. These parameters can be altered, meaning if one's genetics are such that one needs to have things clean, clear-cut, black and white, and the actual experience is gray, that individual can become emotionally dysregulated. The experience doesn't fit their model for how they feel things should work. But rather than getting too caught up in the cause, what's important is that all parties do their best to be in this moment, to have a positive attitude, understanding that we are all interdependent. We all affect each other, and we can all change. We need to be looking at what we can do now to heal.
Thank you, Dr. Bob. Yes, I remember my mother asking, was it something I did? Is it my fault that you're this way? And honestly, I'm not proud of this, but I remember somewhat insensitively at the time because I had heard this term thrown around and was reading all the books I could get my hands on. I told her that she created an invalidating environment and that it didn't help, and that later, though, I did express that I knew she was doing the best that she knew how to do, as a young mother at that time. Everyone's only doing the best that they can where they're at with what they have, the skills they're equipped with at the time. So I don't blame my mother. but I am aware of that connection to the environment being invalidating and that potentially being something that can set you up for BPD. And the only thing, though, that was important at the point of my actual diagnosis, as you said, was that we accepted what was in front of us and worked together for the common goal of healing. So thanks, Dr. Bob, for touching upon that. Let's move on now to the role of medication in these disorders. And before we do, I'd like to mention that OPI had a press release go out this past week, and it was on GeneSight, which is a system for genetically testing for which medications will be most effective and have the least amount of side effects on a completely individual level. And I was so surprised to learn about this because I, for one, and I think most people have no idea that this type of technology exists. So I think this is awesome that you guys offer this. And one of the people that I talked to said that it's a swab that just goes on the inside of the cheek, and they can actually determine what medications will be best for you instead of, for me, I felt like a guinea pig or a lab rat when I first went to get help and they were trying all these different meds on me, and now we don't have to do that, which is amazing. Just so everyone knows, if you're interested in this, a link to the press release will be emailed out to everyone who registered for the webinar today. And also at that time, you'll have an opportunity to sign up for OPI's newsletter, which I recommend signing up for because you'll hear about things like this and other happenings with them. So that all being said, let me throw the mic back to Dr. Bob, who will talk about the role of medication. Dr. Bob?
Thank you, Debbie. Yes, with regards to GeneSight, genetic testing in psychiatry is actually quite revolutionary. Before this test, our field had very few tools compared with mainstream medicine, which is able to quantify blood levels, etc., and genetic predispositions using blood tests. If you have any questions, please, after reviewing the document, please do reach out to us by phone or via contact form on our website. Now, on to the medications. What is remarkable, I think, is with the right medications, it is now possible to help stabilize a young person whose thinking has become so rapid, I'm referring now to bipolar, that they misinterpret the world around them, can even experience delusional beliefs and such. By taking medication for a number of days, that state is able to be altered to one in which an individual can be at peace and see the world more clearly. It's really quite a remarkable experience to see. So to the outside observer, you would think, as a parent, all right then, take your meds, and you can go along feeling pretty stable and functioning well. Why don't you just take and stay on your meds? But as many of you parents know, the willingness to take meds can be quite low in young adults. Let's talk about why this is often the case. Basically, the young adult understandably is frightened to acknowledge that there may be something wrong with them that requires them to have to take an external medication to resolve it. It's quite a blow. It's quite a blow. But in addition, unfortunately, the side effects of some meds used to treat bipolar can be significant. It's subtle but significant. A young person also may not want to take their meds due to their feeling of not wanting to suppress what they experience as their creativity. Reality is much more complicated, but that's how they feel. And there is some basis in that some meds have a potential for some individuals to kind of put a subtle damper or a kind of slow down what they feel is their mental speed and processing. And the manic state can be a very desirable state. It comes with a lot of energy, but when it goes over the top, when it goes over the edge, the person can really become so disorganized and dysfunctional, it doesn't feel great. We try to avoid the state of mania with the use of medications. Over time, one can create a definitive, although unfortunately complex medication treatment that can be constructed to helpfully affect those who suffer from bipolar. Meds include anticonvulsants. They were previously used exclusively for those suffering from seizure disorders. Medications such as Depakote that Debbie mentioned, or Lamictal. Biochemically, these meds are really changing the balance and equilibrium of chemistry in the brain. In the case of a bipolar disorder, these meds are used to stabilize mood. They're also classified as mood stabilizers. They can also help to insulate the young adult, which is very important, from manic and depressive swings. People with bipolar are often treated with more than one medication. The use of mood stabilizers many times needs to be augmented by other meds, such as antidepressants. And with these meds, the treating physician must be very careful because these can sometimes stimulate mania. The doctor must skillfully and closely monitor the young adult to see how she or he responds, especially at the early changes. Another drug used in the treatment of bipolar disorder is lithium carbonate. Lithium is a naturally occurring substance. When one is deemed only to truly have a bipolar disorder, as evidenced by manic states and extreme states of depression, lithium is used. For acute manic episodes, the young adult cannot think clearly and is experiencing extremely disorganized thinking, an antipsychotic medication such as Risperdal or Abilify may be prescribed to help that young person come down from these manic episodes and reduce their anxiety. These particular medications are non-addictive.
Thank you, Dr. Bob. Just want to interject a question real quick here. You mentioned lithium. Is lithium an old school drug or is it still commonly prescribed?
Well, lithium has been around a long time,
Mm-hmm.
and to some degree may be perceived as an old school drug, but it is still a medication that is prescribed because it's effective. And it's particularly effective with those suffering from depressive symptoms.
Okay.
It must be monitored. You know, there are blood levels that need to be drawn, and there are precautions that need to be taken, many regarding hydration, adequately hydrated. The great thing about this medication, that is, it can be managed by established blood levels, which allows both the clinician and the young adult to manage the medication dosage more effectively. Lithium may also be used as an adjunctive medication to help individuals who experience depression and who have not responded to traditional antidepressants, even if they don't have bipolar disorder.
Wow, okay, because I know I've heard lithium for like 20-something plus years, so I didn't know if they had done away with it or, if that was something that was still in use, so thank you for discussing that. And also, as far as medications for someone with borderline personality disorder, what are your thoughts? Because I'm really open about this on my blog and my books and everything, so some of you guys already know about this, but in the past, I was prescribed mood stabilizers like Depakote and a low dose of Risperdal for anxiety purposes, not for the psychotic aspects of it or antipsychotic aspects of it. Now, keep in mind, this was after a half-an-hour visit with a psychiatrist that I'd never met before. So when it was clear, though, when I started to get stabilized in the sense of getting consistent treatment from the same practitioner, and we realized that I did not suffer from bipolar disorder, but rather BPD, things obviously changed in terms of the medication. And then they ended up putting me on a low dose of an SSRI, which is like an antidepressant for those of you who are listening. So sometimes Zoloft, Prozac, Celexa, those types of drugs. I happen to be aware of them because I've been on all of them. And a low dose of an anti-anxiety medication. So while these help, though, I honestly didn't really see a major transformation in my life until I began DBT in conjunction with these meds. So I know you're going to get to the topic of beyond medication in the next slide, but as far as your experience with medication and BPD, what have you personally seen?
Well, Debbie, I think your experience is quite common, actually, and I thank you for sharing that. Where there can be benefits with regards to medications for those with BPD, particularly when it helps to perhaps decrease anxiety, to perhaps decrease the depression, and some mood equilibration. As you mentioned, medications work best in conjunction with other things, with other therapies, and we'll get into that shortly. We've already said that our systems, our own internal systems in the world, are interdependent. So if we're able to decrease anxiety skillfully, or insulate us from the more profound experience of depression, or even just decrease the internal noise and fear a little, one can be more present and one can be more focused and therefore available to achieve goals and joy in this moment. Some of the medications that are classified as antipsychotic can actually be very useful for those with BPD in very low dosages simply for decreasing anxiety. And they're non-addictive. And you don't create tolerance issues.
Okay, well that makes total sense. All right, thank you so much for that, Dr. Bob, for clarifying that issue. Okay, and now we're moving on to the topic of those complementary therapies and other things that we can do in addition to medication to build that life worth living. Dr. Bob?
Yes, Debbie. And it's so important to become aware that it's always a two-way street. And what I mean is the external world affects our inner biochemistry and vice versa. The nature of true transformation and change is simply being present in this moment and open to possibilities, which reinforce the change of our own biology, and I would suggest our own neurologic wiring. We can actually create new pathways and reinforce them from our moments of joy and pleasure in our lives. We can create more and happier lives. We change, and we can experience an increased probability of a life worth living. And now, beyond medication. In general, all people seek validation, affirmation of a sense of self, and they hope to find and express their joy with others. With those with bipolar, in addition to medication, they can benefit from cognitive behavioral therapies such as DBT, as well as analytic and psychodynamic psychotherapies. They may also benefit from a treatment known as transcranial magnetic stimulation, which recently has been approved by the FDA here in the States, which can help ameliorate episodes of depression. During this treatment, an electromagnetic wave may break habituated brain patterns so that the brain may re-equilibrate and reorganize in a more balanced way. It's interesting that the human brain is very sensitive to frequencies, such as frequencies of light, of sound. And the frequencies emitted during transcranial magnetic stimulation are simply other frequencies on that same electromagnetic spectrum. The side effects of these treatments are minimal. Possibly a brief headache that is responsive to aspirin, but there is no memory loss or anything of that nature. It is usually done, the treatment is usually done, 5 times a week for about 4 weeks. They're usually 20 sessions, and the sessions themselves are 20 minutes in length. And this can be done on an outpatient basis.
Oh, wow. Okay, so is this something that is actually offered outpatient at OPI?
Well, it's not offered on site, Debbie, but we work with people in the community of practitioners who do provide this treatment. And once this treatment is initiated, those practitioners become part of the young adults treatment team at OPI.
Got it. Okay, thank you.
I think that we can now begin to talk about the psychopharmacology in BPD. In BPD, it's not as dramatic. Meds may be used to regulate anxiety, regulate mood, regulate depression. But primarily, treatments such as DBT seem to be the most effective. DBT helps us change strategies and shift core dysfunctions in thinking. As most of you know, Debbie often shares that she no longer meets the criteria for BPD in large part due to participating in dialectic behavioral therapy. So the potential for a very positive outcome using this treatment modality is actually quite high. There are also other therapies which have been proven to be as effective as DBT, such as mentalization, transference-based therapy. However, in my experience, DBT has been the most helpful simply because it's clear, it's simple to learn, to teach, and to use. We are able, through these therapies, to literally create new pathways in the brain. The dendrites of our neurons can actually regrow. In addition, with BPD, changing environment, making new friends, and moving on in their lives can have a demonstrable impact on young adults. There is a process of transformation that can take place. During transformation, we can develop a faith that joy can occur in the next moment, even if we're suffering in this moment. We do this through incremental guided experiences. We do this through an exploration of our passions, which at OPI we foster through various clubs and activities. These experiences also occur in the context of supportive relationships, opportunities in school, at work, and achieved through socializing. True change and transformation can only happen in the moment. And we create and support validation for being in this moment. We find opportunities to elicit and express passion in a joyful way. We learn to share it with others. And this sharing of joy with the explorative spirit of a child who's learning to walk, with the spirit of the beginner's mind, the mind of the child who is open, tempered by the wisdom of experience and time, is all part of the transformative process. So how do we do that? Well, in our programs we have activities that range from musical jam sessions to creative writing to hiking or playing basketball. When we feel this positive energy, this creative energy, this positive affirmation of our own abilities to persevere and express passion, we move on, we move forward. This fundamentally is a building block of reconnecting with our creative selves that allowed all of us to learn to walk and talk and achieve those monumental developmental milestones we did as children. Young people who are suffering from emotional issues desperately need to reconnect with this place within themselves. And we at OPI and Rowan program help facilitate and foster that connection.
Thank you, Dr. Bob. You know, I've said it before, I've blogged it, I've put it on YouTube, but I wish I had known about OPI back when I was within the age range to receive the residential services, because, you know, the program is incredible, and one of the things that makes it so attractive is that the whole person is treated, and that's something that I didn't experience when I was in the depth of my suffering, you know. So would you explain a bit about what that means or entails to be treating the whole person?
Absolutely, Debbie. It's an aspect of our treatment programs that's incredibly important. At OPI, we do look at the whole person. As we discussed, while medications are essential in many cases and in many situations, they're not sufficient to build a life worth living, which is really the ultimate goal for long-term success, happiness, and well-being. In our programs, we carefully support and monitor our participants over time. In this environment, we're able to paint a picture that is more comprehensive to help accurately define the diagnoses and determine any biologic contributor as we monitor responses to medications. We observe mood changes that can take place as a result of cognitive and behavioral therapies. We review previous medical records. We speak with prior therapists. Our treatment team looks at a variety of things, including the opinions of you as parents. We look at the participants' grades. If they're in school, if the grades are an issue, we dig deeper to determine whether this is connected to a bipolar disorder, BPD, social anxieties, learning disabilities. We just don't assume that everything is due to their disorder. It is always more complex. We look at situations in which your child may have been terminated from employment or has quit his or her job. We observe how they interact with peers in an academic setting and a non-academic setting, how they utilize their free time. Their interactions in many of our clubs and activities are incredibly revealing, and how they interact with a diverse team on our staff. So this is much different, obviously, from an outpatient experience where your son or daughter may spend up to an hour at a time with a physician, a doctor, a psychotherapist, who understandably is only getting a brief picture of your young adult's life and world and experience. Your loved one is so much more than a diagnosis, and a great way to really address their wholeness is in the diverse immersive experiences provided at OPI and Rowan. It's essential, in addition to all of this clinical treatment, that we help young adults find their passion, express it as joy, and learn to share it. This is actually one of the greatest antidotes to the anxiety associated with what's called attachment disorders, which many of our young adults experience. We encourage activities in a unique setting, in an environment where we actively facilitate the discovery of passion and encourage young adults to express it with joy. We currently have 17 clubs to engage young people with a variety of interests, some of which they've yet to discover. They learn to connect with the creative part of themselves, and that is very healing. They learn to share with another person their joy, which helps them establish a foundation and basis of healthy communication, something many have been lacking. They're often ill-equipped to be successful in the world given the added challenges they face. And often, up until we see them, no one has adequately dealt with all these challenges and complexities. When we identify these disorders as early on as possible and intervene with effective, comprehensive treatment, the outcomes are much more positive. The only thing that really sets us apart, I think, one of the many things that set us apart with regards to the treatment of borderline disorder is that we're the only residential treatment center in the nation presently that treats young women and men ages 17 to 28 with borderline disorder. The new literature states basically that borderline disorder, which was thought to be predominantly a disorder of females, is not. It's 50% male, 50% female. So that being said, Debbie, would you now lead us in the opportunity for our guests to ask us some questions?
I am happy to do so. Thank you, Dr. Bob. Yes, I just want to comment on this as well, the aspect of treating males. People just don't know that there are resources out there that services are offered to males that have borderline personality disorder. I know that I recently watched something on TV. A very important figure in the news was talking about how he had received treatment for borderline personality disorder, but it was outpatient. So OPI really is the only residential treatment center in the nation that treats young men. And so whenever I see someone on Twitter, like a young adult male, reaching out for help, or on Facebook or anything like that, I definitely let them know about the OPI and ROAN program. So that is a huge distinguisher. And I should also mention that the facilities are separate for men and women. So the young men are in different apartments than the young adult women. So that's important to know also. Okay. So let's go on to our Q&A time. So now is the time, everyone. If you would like to ask a question on the microphone, you can use that My Mood icon up in the middle of your screen. So you just click on My Mood and then click on Raise Hand. That will indicate to us that you would like to be unmuted to speak. Other than that, if you would rather type your question in the chat box below, please make sure that you change that little default setting down there where it says Send to Presenters. Just click that little down arrow, choose Send to Everyone, and I'll test that out and show you. Hello. And you can type your question in there. So please do so. And I'll read the first question coming in, Dr. Bob, from Cynthia from the United States. Cynthia asks, can you comment on the effect of long-term Adderall use for BPD, as I am wondering if really unmonitored long-term use is contributing to behavioral issues such as anger and rage and severe mood swings in her child?
Well, Cynthia, that's really a very good question. In general, could it be contributing? It could be. But a lot of that has to do with the dosage and somebody's response to dosage. It is a very important question because depending on the age and the obligations of your child, many need to function in a kind of school environment in which they have to pay close attention and support may or may not be available. So the point is, they do need to concentrate, and they do need to be more present, not only in academics, clearly, but sometimes in relationships. So there is a balance, as you suggest. There will be a dosage, generally, that will assist your child in gaining the concentrational benefits, but sometimes if the dosage goes beyond a certain point, that individual may respond with irritability, etc. The long-term issue is, again, somewhat more complicated, but I don't think the length of time is as important as the follow-up and how frequently is your child being seen, and the good news about these medications, the ADD meds, is they act very quickly. They act quickly and they leave the body quickly. So generally, if there are issues that you're concerned about relating to irritability, etc., generally it's occurring around the time of the dosage. So that therefore, after somebody takes medication, it gets more complicated. There are short-acting and long-acting, but the side effects you have an opportunity to see fairly rapidly. So therefore, you can make that determination, meaning if somebody, after just taking an Adderall dosage, let's say, of a quick acting, in an hour or so, if you notice they are becoming more edgy, more irritable, perhaps that dose is too much.
Thank you so much, Dr. Bob, for addressing Cynthia's questions. The next question comes in from Deborah, and we have another one from Kim. That's a really long question that I'll get into. I do want to mention, because Dr. Bob and I checked in before the meeting, that unfortunately he can't address specific medical questions here today, because it's really important that you reach out to a local medical or psychiatric mental health professional for certain questions, and we thank you for your understanding with that. For example, Deborah is asking, what recommendations can you give for a 5-year-old child of a parent with BPD and bipolar, and the child shows indications of both diagnoses? And Dr. Bob, so that would be something that they would have to check in with a professional locally for advice on that, correct?
Absolutely, absolutely. And again, I would issue a note of caution in that, as a child psychiatrist, I saw many young children. So the good news is it's very difficult to make that kind of diagnosis on a child that young. But that is not to say that with proper therapy, with proper treatment, if you're picking up something, if you're sensing or picking up some sense of disequilibrium in your child, you may be picking up something. But rather than the diagnoses, this is an opportunity to reach out, to see if you can get a mental health professional to see the child. So the good news is, at that age, they are very, very, very flexible, very, very resilient. So you can reach out for some resources for that child, but be careful of diagnoses.
That's really helpful and encouraging, Dr. Bob. Thank you for that. I'm going to read Kim's question now. It's quite long. And again, Kim, I think this is a situation where you'll be referred locally, but still, just as Dr. Bob had some encouragement and feedback for Deborah, he may have some for you as well. So let's go ahead and I'll read that aloud. So Kim, her situation is, she says, I'm hoping to get ideas for our current situation. Undiagnosed 22-year-old BPD daughter, but all behaviors consistent with BPD. Currently seems manic, as you described in the presentation, with bipolar. She's on the verge of becoming homeless. She cannot organize enough to prevent this from happening. She also suffers a host of physical issues that no other cause can be found for after multiple doctors and diagnostic tests, that she says prevents her from caring for herself. She hints that she may want to move in with us again. Last time her behavior was so I'm sorry, I don't know that word, that after a year of her treating us abusively, we told her that if she didn't like the way we were trying to help her, she could leave. She did. We don't feel safe taking her in again. She denies she's mentally ill. She treated friends and family so badly, no one will take her in. She's afraid, obviously. She feels abandoned, obviously, but how do we address the many reasons we cannot, for our own mental health, take her in when her thinking is so distorted? She seems to rewrite, quote unquote, actual history. So explaining what was unacceptable behavior before is probably useless. Also, she seems not to be able to control much of her behavior. We have spent all of our savings to help over the last 3 years. We're broke, she's broke, we don't know what to do or where to go. Dr. Bob?
Well, just to share with you, Kim, I'm sorry. I'm so very sorry, because this is the pain and the suffering that parents unfortunately have to experience. Because in the end, your 22-year-old must acknowledge her role in why things are happening to her. And so that out of your love and your compassion and your care for her, you have to really set some limits and really determine what you can do and what you can't do. Bringing her back home now under these circumstances, and again, you have to really take the opportunity to see if she will consult a mental health professional, somebody, because it doesn't help either party. To come home under these circumstances can be quite difficult. But there are so many other factors. So in essence, I think you have to be strong, and in your love and in your compassion for her, or him, I'm sorry, you have to set some limits. And you have to really offer what in your heart and what your knowledge and mind say can help, meaning some treatment. And if she denies that there is anything happening which she could benefit from treatment, if she denies all of that, you can't do much. So there's a lot of suffering for you. And again, I think the most important thing is to stand your ground, come from a position of love and compassion and non-judgment. And the reason that you are not allowing her home is not, or him home, is not because you don't love them. It's because you know that that will not resolve or provide any opportunity for really moving forward and help. So again, sometimes a third party, whether it be an outside third party, a friend, somebody to bring to her the consciousness of the 22-year-old that there's something going on and they must begin to address this issue.
Thank you so much for taking the time to answer Kim's question, Dr. Bob. And Kim, thank you for bravely bringing this question and for reaching out to ask about this. It's so important, and we do have so much compassion for you and what you're going through with your daughter and your family right now. And next is Gayle from Ohio. Gayle is asking, Dr. Bob, are you familiar with, and I'm not sure if this is a typo, but it says 22q deletion syndrome, and if so, how does this syndrome affect mental health treatment options, particularly for BPD? I've never heard of that personally. But
No, I apologize, because I haven't heard of that. Please, could she explain to us what it is? I'm interested.
Okay, so Gayle, if you wouldn't mind doing that, I'll continue on with some of the questions that came in after you, and if you would expand upon your question a little bit more, then we'll get back to you on that. Okay, and now Thomas from Denmark is asking a question. I think this is something that will have to be addressed with a local medical or psychiatric professional, although Dr. Baum might be able to offer some feedback in general about it. Thomas from Denmark is asking, is it best with a low dose of lithium or high in treatment of bipolar?
That's a very good question. And, you know, basically the rule of thumb is that you use the lowest dosage that will provide the optimum reduction in the symptoms. Lithium is a particular medication where there are ranges. And basically, there is a range. If you go beyond a particular range, sometimes I'm pretty sure it's standardized, but there's a range where if you go too high, you can get side effects. If you go too low, it's ineffective. So it's really quite individualized. So I don't know that one is any better than the other. The issue is at the dosage that you're taking, and when the blood level can tell you where you're at in terms of the range, if that dosage of medication is helping reduce the symptoms or keep them in check, that is the appropriate dosage. So again, I'm not sure, particularly with lithium, because there is a designated range that defines both effectiveness and also possibilities of experiencing side effects. You try to stay within that range. The tests are easily available, and I'm sure in Denmark that they're easily available, and you simply stay within the range and you work closely. You work closely with your, in general, I think it would be attending psychiatrist there in Denmark.
Thank you, Dr. Bob, for addressing Thomas's question. Next, we have Kathy from South Carolina. Kathy says, our daughter has estranged herself from the family. Her husband is in contact with us. According to the therapist she is seeing, she is suffering from BPD. Does this estrangement fit BPD? She is our only child. She's taking DBT therapy, but she does not feel like she is BPD, even though her husband feels she meets the requirements. Thanks.
Well, again, the experience of the estrangement certainly could be consistent with BPD, but it could be consistent with many other things. And I think the most important thing is that certainly she's in a place of disequilibrium with her husband, and certainly under a tremendous amount of stress. So I think irrespective of the diagnosis, is she receiving adequate help? Is she receiving therapeutic support and help? That certainly could be demonstrated in her ability to really interact with her husband and interact with her family. The diagnosis of the BPD, if it is present, is a bit more complicated in that the solution, as we have been saying, is far more complicated than giving her a medication, which may decrease her anxiety and which may be helpful. So I think the bottom line is that if things are not working, well then obviously one can go and seek further consultation and find a treatment regime and treating therapists, treating psychiatrists, whomever is being utilized that can communicate with both parties. And I think that can be helpful to create a space in which your daughter's therapist can serve as a bridge of communication for her and her loved ones.
Thanks, Dr. Bob, for addressing Kathy's question. Hopefully that was helpful to you, Kathy. The next question comes in from, and I hope I'm pronouncing your name correctly, Hallie, H-A-L-I, from Las Vegas, Nevada. And Dr. Bob has, he'll respond to this in general in terms of cost and insurance and so on, because Hallie's asking, sounds wonderful, how do families afford it?
Well, in order to get that information, really, I appreciate the question. And it really depends on the program your young adult enrolls in, their length of stay, and all those variables. I'm really unable to provide detailed financial information during the webinar, but please do reach out to us, to our admitting department, our Director of Admissions, by calling us or using a contact form on our site. And she'll be able to walk you through the details and, most importantly, give you the options and explain how everything works. And I thank you for your question.
Yes, and Hallie, the information is at the bottom of the slide, and we'll have a slide up at the end as well with the website. There's a contact form there, and then the toll-free number. Okay, next is Manuela. Manuela is a sufferer of BPD herself, and she says, I have BPD and have been having emotional spirals due to work and stress, and now have fears and paranoia of losing my job after a messy let go of another staff member. So I'm the supervisor. Can you explain about emotional spiral and BPD and paranoia, how these things are interconnected?
Well, again, the emotional spiral really relates to what we've been talking about, the exquisite sensitivity. And that sensitivity is also linked to our needs, to have things, evolve in a particular way. And obviously you're concerned. And so obviously there is a basis for your concern, and that somebody was terminated and the way it occurred, caused you more concern. And therefore you may become more anxious. So the point is that this is an opportunity. This is an opportunity to use both one's DBT skills, and if you're working with a therapist, obviously this is the time to check in. And basically, if you're utilizing a DBT kind of model, then this is the time to find some skillful ways to deal with the anxiety. It's very natural. It's very natural that you would be feeling scared and frightened. And when one feels scared and frightened, then that's the entree, that's the beginning, that's the opening to what people call paranoia. Because in a sense, what paranoia really is, it's an exquisite sensitivity to the environment. Meaning there may be no basis of your paranoia, but yet there could be some in that you're becoming more anxious, and therefore through the anxiety, your anxiety may be eliciting anxiety in others, and that's how the cycle starts. So that don't let it get out of hand is the main thing. That is it normal for somebody in your circumstances to have feelings of paranoia? Absolutely. Absolutely. The question is how you deal with it. So this is the time. This is the time to really reach out and reach out to hopefully a psychotherapist locally and get the support that you need and deserve.
Mm-hmm. I have to agree with that. And as a peer and someone who has actually spoken with Manuela outside of here, I know that you are a very strong young woman, that you do have DBT skills, and I hope that Dr. Bob's answer was encouraging to you to tap into that strength that I know you have, to tap into Wise Mind and connect with your DBT skills to get through this. And totally, I would be, anybody would be nervous in that situation, and what you've observed, and, it makes us feel vulnerable when we see things like that happen around us, and it's a really major life thing, having a job and seeing something like that happening. So please do tap into those DBT skills, and thank you for your question, Manuela. Okay. Sharon from the UK is kindly saying she really wishes there was something like this in the UK. I will tell you that people, young adults, do fly in from the UK to be a part of the residential treatment program at OPI from all around the world, actually, right, Dr. Baum?
That's correct. That's correct.
Okay, so it is an option, possibly, so reach out to them. Sharon, reach out on the website and reach out to the admissions director on the toll-free number. And Carrie says, Carrie has a question. She's from San Diego, California, and she asks, can one be diagnosed BPD and schizophrenic?
It's, I mean, yes, unfortunately our system is so complex that one can do that, and I'm sure that that's occurring. And
Okay.
so yes, that can happen. I think the issue is what one means by BPD, and and here's the issue and the complexity. It depends on how you define it. As an example, somebody with BPD, because of anxiety, they may tend to see the world in very rigid black or white ways. there may be some characterologic personality traits that somebody with, as an example, schizophrenia may have. But the difficulty is, I mean, the illness of schizophrenia is an illness that is very clearly genetically linked, and very clearly the treatment for that is far, far different than BPD, meaning one would need a, I think, sophisticated pharmacologic treatment for the schizophrenia. And if one looks at the whole person, meaning could they benefit from, as an example, DBT skills? Could they benefit if they're able to, experience some kind of mindfulness, some kind of meditative, some kind of movement, such as Qigong, Tai Chi? It helps center somebody. So first and foremost, the person is a human being. And for, again, it's the same thing in that for a bipolar disorder, I think the treatment regime absolutely, in my experience, should include medications. For schizophrenia, the same. And in schizophrenia, as in every disorder, there is a spectrum. And in general, what's helpful is to focus on somebody's gifts, focus on somebody's assets, and figure out how you can utilize those assets as bridges of engagement. So, therefore, can somebody have both? Yeah, one can say yes. One can say yes, but it's very complicated in that our diagnostic system is not all that helpful. So, yes, it's possible, but the most important thing is about treatment, about what's available to help that person. If somebody is talking about a BPD disorder, then very clearly, as Debbie has said, and I think that this is a very common and basic experience for the treatment of BPD, a characterologic borderline disorder, some form of psychotherapy in addition to everything else, whether it's DBT, other engagements is necessary. If you're dealing with a disorder such as schizophrenia or bipolar, then a medication regime, medications that are suitable to help with the biochemistry are also essential.
Thank you so much, Dr. Bob, for addressing that. And hopefully that was helpful to you, Carrie. Okay, I just want to make note that we have about 15 minutes left of the Q&A before we have to wrap up today's presentation. So we will try to get to as many more of the questions that are coming in on the chat box in that amount of time. If your question is not addressed today, please do go to the OPI Living website or call the toll-free number, submit your question, and we can have someone in the admissions department figure out how to best get an answer to you. Dr. Bob and I are also working on a series called Ask Dr. Bob. So if you would include when you submit your question outside of here, whether we can use your question in that series, and if you'd like your name to be, abbreviated or something like that, your question and the answer given may really help other parents as well who are having the same types of scenarios going on in their lives as you. But let's go ahead and address as many as we can here and now. So the next question comes in from Chris in Boise. Chris is asking Dr. Bob, she says, my 22-year-old BPD daughter has moved back with us after a rash decision to move out of state in May. Her counselor was against the move and discontinued care, so my daughter is currently not taking meds or getting help. The relationship she left for ended terribly. She is about to lose her insurance. The resources are going to be limited. I have spent so much time and money. I do not have the resources to help once insurance is gone. She agrees with the diagnosis. Our relationship is strained. I'm trying to be as supportive as possible. Where does a parent find resources for help?
Well, one certainly is you could certainly call us, and depending on what the insurance situation is, sometimes it's unfortunately rare, but you can call us and see if we can be of some assistance. I think the other opportunities for help is that in the BPD community, there are many online support groups. There are chat groups. There is Debbie's site. Um, but again, there are different support groups through DBT, and there are national organizations which could provide a level of support for you in helping you have the strength and equanimity and to continue the compassionate way in which you've been trying to deal with your daughter. The situation is very difficult, and I do think you need support. So you can reach out to, there is a group called the NEA BPD. There's a national association that provides support for both families and also for those suffering from BPD. And one can Google that. Um, and that is some opportunity for support for you.
Yes, yeah, I agree with that. And Chris, NEA, BPD, National Education Alliance for Borderline Personality Disorder that Dr. Baum mentioned is excellent. You already know about healingfrombpd.org. I came across some message boards in the past couple of weeks at bpdfamily.com. So there is a lot of interaction amongst parents in those message boards, and you can remain pretty much, pretty anonymous there and get some support and connect with other parents. So and do reach out to Shannon, is the director of admissions, and Anne is also working in admissions, and they are wonderful. So definitely give them a call and see if there is something that can be done with your current situation to help your daughter, okay? And Dr. Bob, Gayle is now responding back about her question from earlier, Gayle from Ohio, about the 22q. She says it's not a typo with a smiley face. She says it is a condition where a portion of someone's DNA, specifically related to the 22nd chromosome, is completely missing. It is not well understood, but my stepson was diagnosed with it earlier this year. Other syndromes like DeGeorge, VCFS, and others are now being understood as variants of the 22q deletion syndrome. Well, that's interesting.
Well, I thank you. I thank you for giving that information to us, Debbie. And
From Gayle.
Gayle, I thank you. and truthfully, this whole field is just really coming alive now. And, there are all kinds of research done on genetic testing, and I thank you. I was unaware of that, so I'm not sure of its relationship. But thank you for bringing it to our attention. Thank you.
Thank you, Gayle. And Chris had, who you had just spoken to before about her daughter, had given some additional information, and part of it is regarding a medication that her daughter stopped cold turkey and is having severe withdrawal symptoms. So we need to advise you actually to definitely immediately have her seen, right, Dr. Bob, locally for help with that issue.
Absolutely, please. Absolutely.
Okay. Unfortunately, it's not, we can't do anything to help on this presentation with that, but we're concerned and want to make sure that you are following up with getting her the proper medical attention that she needs locally. And then Gayle from Ohio is also saying, I should have also mentioned that mental illness is one of the many possible symptoms of a 22q deletion syndrome. Well, you've certainly piqued our interest about this, and we'll look into it more. Gayle, thank you for that. And Deborah from Missouri is asking Dr. Bob, do you see much correlation between BPD and OCD? And I will just interject quickly before he answers that before I knew I had BPD, I was diagnosed with OCD, and it's in remission, but definitely there was I don't know if there's a correlation, but I definitely simultaneously had both conditions, so I'll throw it to Dr. Bob.
Yes. I'll tell you, this is part of the complexity, really, of our diagnostic system. And that is it possible? Is it possible that somebody can have OCD symptoms and have BPD? Absolutely, absolutely. And one way of looking at it is that we know that the individuals with a borderline disorder are exquisitely sensitive to anxiety, to stress. And then there are characteristic ways in which we all deal with stress. One of the ways from early childhood is that when we're anxious, we become obsessional and or compulsive. And this is part of all of us. The mind will begin to, if you see the child who asks you 10 times, can I have a cookie? And you say, well, no, no. And then so they ask the 12th time. And then they ask another time, thinking maybe the 25th time you'll change your mind. So it's this kind of obsessional kind of thinking and compulsivity, which individuals with BPD, I think, do have. But the compulsive portion, the obsessional portion, meaning we want to control by obsessing about it. And you deal with the anxiety, you bind the anxiety by different defenses. And so the obsessional compulsive kind of defense, the kind of way of dealing with anxiety is quite common and is present in many situations. The OCD is also present a lot, actually, in those with bipolar disorder. So I'm saying the obsessional characteristics of ruminating with stuff, of a rigidity of thinking, of seeing things in a black or white way, all of that stuff does have a correlation to the obsessional compulsive type of thinking. So yes, there is a relationship. And yes, I don't think it's that uncommon, but it's a matter of degree. It's a matter of degree. And I think the complexity also is if truly somebody has a lot of OCD symptoms, well, then the treatment of OCD is fairly specific. It's quite behavioral, and part of the difficulty is in order to be successful in the treatment for OCD, you have to be fairly regulated, because the treatment is in itself is very detailed and very compulsive. So
It's true.
So I mean, you have to be compulsive to really even engage in the treatment of OCD. But that is the state of the art. So I guess the point is this, is that if one continues to look at the person as a whole person, meaning how do you deal with your anxiety? How do you deal with your fears? How do you deal with change? How do you deal with accepting that things may not occur the way we want them to, or even the way we think the probability of occurrence is very high? How do you deal with that? Well, you can deal with it by denying it. You can deal with it by repeating the same thing 10 times, hoping for a different outcome. You can have different rituals to protect yourself. Meaning, everything from making lists, or I have to go and check this, or I have to go and do that, to somebody who actually checks out, meaning somebody can disassociate, as in BPD. You can actually step out of yourself or step out of the situation. So these are all ways that we have psychologically, all of us. And one way, a simple way to see it is we all have our own defenses, psychological defenses that we all use. And then those defenses cross all diagnostic lines. So that there would be obsessive compulsive type defenses with somebody with a BPD disorder, yeah, absolutely, absolutely. And you can see those defenses in many, many different kinds of disorders. The issue is degree, and the issue is your treating environment, your treating therapist, your treating team, how they're going to deal with it. So I hope that helps.
Thank you so much, Dr. Bob. And we do have to wrap up now. I know that there are a number of additional questions that came in and kind comments, including from Peggy, wanting to thank us for this informative webinar, Dr. Bob. And also, just want to mention, because this is important, Chris said she should have said her daughter went through withdrawals. She ended up in a hospital a few months ago. She's not withdrawing right now. Okay, thank you for letting us know that, setting our minds at ease about that. And there continue to be questions that come in the chat box. We really do want to address them and be able to get you answers that can help. So please do reach out using the contact form over at opiliving.com or call the program toll-free at 1-888-558-0617. I will briefly address a couple of the questions that I can address, which is which are, one of them was someone just asked if why people, Kiara, is asking why people with BPD have a hard time keeping jobs. I have some articles on that on healingfrombpd.org. Erin's asking how can institutions such as OPI be found in Canada? I would reach out to the admissions department at OPI Living to see if it's a possibility. They do have people coming in from Canada and all different countries into the program, so definitely check that out. And also, if that's not a possibility at all for you, the admissions department sometimes does have resources and information, so that may be helpful to you. We want to thank you so much for your time, for taking time out of your Saturday to be with us. Again, to reach the programs, you can go to www.opiliving.com. Call the program toll-free within the U.S. at 1-888-558-0617. And there's also another site once you get there to OPI Living that connects to the ROANNE program, ROANNE program.com. And that was mentioned earlier with regards to the residential treatment options available to both young women and men who have BPD. So thank you so much for your time. We look forward to hearing from you guys after this presentation. We hope it has been very helpful to you, and we hope you have a great rest of the weekend. Bye, everyone.
Thank you, Debbie.
Thank you, Dr. Bob.